actually in another epidemic about, a few years ago, the Zika epidemic in Brazil, when that network was used to provide telemedicine services in education in outlying areas. Dr. Matos will talk about specifically that. How can we use remote teaching to build the capacity, to build the workforce that we need to address all the needs for congenital heart disease specifically, and I believe rheumatic as well, Sandra. So up to you, Sandra, thank you.
Thank you very much, Bistra, Jason, Dr. KK. Wonderful opportunity to be here with you. And well, I do have a long title for a similarly long story, but a short time. So I'll try to be very concise about what I present here today. Now, I represent this NGO called the Heart Circle. The Heart Circle works in close partnership with two other institutions, a maternal cardiac unit and the Teaching and Research Center. We are held together by the cellular seats, like a holding, and we've been in operation for over 26 years in Northeast Brazil. We represent each one of our parts by a different color, and the maternal unit is based on a larger hospital facility, as Bistra mentioned, the Royal Portuguese Hospital in Recife. The Heart Circle has its own area. We call it the Heart House, and obviously teaching is done largely online and sometimes in different places. Now, together we have been working, as I say, for over 26 years, and we call our work model LEGOS, which is very much like what you all have been talking. We use it as an acronym for Lead by Empowering Groups to Optimize Solutions. And our worries have always been the fact that there are many solutions which are preset and developed sometimes by people not involved with the problems. And when applied, they may fall short or exceed the problems. So using the little childish way of presenting it, but we always try to group people first and lead by empowering people. And for my colleagues that spoke before me, I think that was very important. One of the comments was sometimes empower is just to talk the same language. And I think it's very, very important when you start moving around and trying to spread knowledge and change policies and ways that people practice. When we do that, sometimes we find other solutions from the one we expected, sometimes new problems, and then you group people again, you start the whole process. So at the end, your final project may be different from what you envisioned in the beginning, but I think it's more likely to reach what you're really trying to achieve in a given reality. So I've just shared with you an experience we had over 7 years in the state of Paraíba, which is roughly the size of Croatia in Northeast Brazil, and nearly 4 million population spread throughout 223 municipalities. We are based in the southern neighbor state, Pernambuco. And until 2010, more or less, Paraíba had a major challenge with children with heart disease, what we all know about lack of resources, late diagnosis, poor results, and as mentioned also by some colleagues, it's very hard to do a transposition surgery, a switch operation in someone with this level of nutrition. So when we were approached as the NGO to work with the state of Paraíba, with the health team there, despite being neighbors, we felt it was very important to understand the problem. So we interviewed lots of people. And then we found some logical things, yes, low detection rates, lack of personnel, but it really called our attention that despite of the low resources, there was no teamwork. And we felt that that might be a way to start our work in Paraíba. So we proposed this solution to set up a network which would have as its centerpiece education, and that would be heavily based on telemedicine because of all the distances that we would have to spread our ideas. So the network, the total cost for 1 year of this network, which would involve acquiring equipment, doing screening, and providing surgical treatment to up to 30 children, 64 children at the time they weren't doing operations there, was similar to the cost of 6 children with complex congenital heart disease that had been transferred under legal action, having to go to private hospitals, sometimes use helicopters and things like that. So the government of Paraíba approved this solution, and that's how the Pediatric Cardiology Network came to be. So the main problem was cardiology. So the first thing that we did was to set up a group of cardiologists to be on call on a 24/7 basis for the whole state of Paraíba. So this was the first step. And as mentioned before as well, data is fundamental. Data wasn't being shared. So we developed a database that would run in every desktop, laptop, cell phones and all these, with all the information of the patients and a timeline about what was happening with them. And everyone that was a member of the network would have access to that database. Then there was a lot of talk about the network protocols with managers, health people. And we had at level 1, we called the screening with physical examination, focused physical examination, checking for the heart, pulses and all this, and doing a pulse oximeter test. Babies that failed that would go on to level 2, very similar to what our colleagues showed with the fetal scans, but here would be neonatal scans, echo, a little tablet in front of it, and a cardiologist supervising, the pediatricians doing it at the bedside in the countryside, and babies that failed the second test would then move on to a hospital where our team would go once a week to do operations and train the local teams for the pediatric cardiology care. The network's original design involved 12 maternities because over 60% of the babies in Paraíba were born in these maternities. They were reasonably well spread from the coast to the center of the state. They were all linked via telemedicine with our group here in Pernambuco. And as you see, after the first 2 years of work screening for congenital heart disease, we compared with the paper from Christiansen that showed the results from the various continents and showed that Paraíba had very low rates of detection, and those rates were significantly up just after putting the people to work together. With that, the state decided to expand the network to see if we could get full coverage for the public health, and this was the final design of the network with 21 maternities and still the pediatric hospital. But then we started having the new challenges. We were working with the neonates, but then what could we do for the older children with rheumatic fever, children that had been born before the network? We were not being able to address those. And then we got together, grouped people again, and decided to do task forces going on to the countryside to seek these children in their local place of birth. The initial year was very good, but we learned a lot with that initial year. That was in 2013. We did 1 week, 36 volunteers, and saw about 500 patients, but we also saw the opportunity to get our training to go to these distant, to the remote sites. So from the next year onwards, the caravan would not only see patients, but also train people locally. And then we did this every year. And at the last time that we did it together, it was a 2-week with 120 volunteers and over 2,000 patients, over 2,000 students trained during this 2-week period that we stayed there. Then on the second year of the caravan, we realized that some children that we had seen on the first one had difficulties reaching hospitals and going to other places. And that was another challenge. So we set people together again and decided we needed to find a way to help them adhere to protocol and follow on this line. So we look at the map of the state. We had the 3 main cities with a room with computers that we were talking with the local teams regularly. And we decided to just open another 12 rooms in the more remote sites. And then we got the local teams, nurses and doctors, trained them to be able to work with us, got the cardiology team to also supervise those groups of people. And then we bought some big pieces of machine, 3 sets of equipment, because we didn't have resources for all the 12 and probably would be needed. But we put a portable echo machine, a Holter monitor, an electronic stethoscope, everything that we needed, and called this the echo taxis, which was basically a way of getting people to be involved with the idea. And the first week of a month, the echo taxis would be on the first, on 3 places in Paraíba, the second week on another 3 places, and the other one, another 3 maternities, another 3 maternities. At the end of a month, we had 12 new outpatient clinics and 1 full week with echo equipments and everything that the maternities need to follow on their children. It was very, very good. And this is still going on until now, even after we have finished the project. I wish we had time to go on for many other things that the network managed to achieve, but I will just mention briefly. The first thing was how to deal with other neonatal conditions. People call you about a transposition, but they will call you about spina bifida or extreme prematurity. And the state agreed that we could get some perinatologists on board, and they helped us tremendously, not only during caravans, but on everyday work. And then, as Bistra mentioned, we were hit by the microcephaly outbreak here, and what we did was to get the teams also together. And then similarly to what we had done for the heart, we helped them do the head scans. And then we were able to very, very early and very quickly map the situation of microcephaly in the state of Paraíba. And then it also evolved we were looking at the children, we were not looking at the mothers, we're having a wide gap of improving the health of the neonates, but maternal mortality and morbidity is still high. And then we were able to put some obstetrics teams on call. So my time is ending on this, but I'd like just to finish saying that this Legos model, we were able to screen over 230,000 neonates and elevate the detection rates from 4 to 14. The most significant reduction in neonatal mortality in Brazil during the time of the network was in the state of Paraíba. We show the plasticity of Legos adjusted to perinatology, microcephaly, maternal health. And the most important thing is that the technology has been transferred to the state of Paraíba. So since we left, the state runs the network and the caravans and everything. Not this year, unfortunately, because of the pandemic, but in 2019, the state ran its own caravan. So we feel that Legos has had the ability of starting on congenital heart disease, moved on to perinatology, then older children, and then moved on for the echotaxis to have people being seen locally, then microcephaly it helped, and maternal areas. So it obviously ended up very different from what we envisioned in the beginning, but it helped us get the health of the state in terms of maternal infant maternal health to be improved. So this is what I had to show you, and to say that obviously, as it's also mentioned before, it's not an easy task. It's difficult to get large groups of people to work together, to go on the same thing. And I really think that empathy is the key issue that we have. That so much that within our walls, we say that to give colors to what we do with Legos, we really say that we let empathy guide our solutions. And that's the whole idea. Thank you.